and all rounding on the wards be delayed till 8:30, so we can actually have a strong attendance at grand rounds. So just want to make sure we get that message out, so please put it on your calendars. The grand rounds are consistently excellent, and we just want more people to take advantage of that. So with that, I'll turn it over to Dr. Steinberger.
Thank you, Joe. It is my pleasure to introduce Dr. Gurumurthy Hiremath, our new rising star interventional cardiologist. Guru obtained his medical degree at the Mysore Medical College in India, which he followed with a pediatric residency in India. And since he felt that his pediatric training was not sufficient, he thereafter had completed another pediatric residency at the Children's Hospital of Michigan. After the residency in Michigan, he completed a fellowship, a categorical fellowship in pediatric cardiology at the University of California, San Francisco, and an additional fourth year of training in interventional cardiology. We were fortunate to recruit Guru in July of 2015 at our institution as an assistant professor in pediatric cardiology with special focus on interventional cardiology. He is very active, not only clinically, but also as a scholar. Guru is currently or principal investigator on 7 local or multi-center interventional cardiology projects. He has 11 publications, of which he is first author on 8, and the majority of these are publications in interventional catheterization. He is an interventional catheterization expert, not only in pediatric, but also in adult congenital heart disease, and works with the adult group caring for adult patients who have congenital heart disease. So without further ado, I invite Guru to tell us about current therapies and future directions in non-surgical treatment of congenital heart disease.
Thank you, Dr. Steinberger. Good afternoon, everyone. I'm grateful for this opportunity to present my talk on non-surgical treatments of congenital heart disease, current therapies, and future directions. I do not have any disclosures related to this talk. Here's what I would like to accomplish in today's talk. I will start with a little bit of history of cardiac catheterization. We'll move on to some benefits of why cardiac catheterization is preferred over surgery for repair of congenital heart defects. I will elaborate on a few select common transcatheter interventions that are done in the pediatric cath lab today. And I would like to end by providing a glimpse of what is in the works for the recent future. As you all know, congenital heart defects are quite common. In fact, congenital heart defects are the most common birth defects and the leading cause of death due to birth defects. If you include bicuspid aortic valve, they account for 3 to 5% of the population has some or the other kind of congenital heart defect, and a significant proportion requires surgery or intervention early in life. Therapy for congenital heart disease has progressed significantly in the last decade and century. University of Minnesota has led this progress from the front, as you all know, in both surgical and transcatheter repair of congenital heart defects. Dr. Walton Lilly High, who, as you all know, is considered the father of open heart surgery, for his pioneering work, which basically performed here at the University of Minnesota, and developed several direct and safe methods of open heart surgery, including the first repair of VSD, the first repair of tetralogy of Fallot, and his techniques using hypothermia and cross circulation. You all know Dr. Kurt Amplatz also very well, who's on your right here. He has developed and continues to develop, as we speak today, numerous transcatheter devices that have revolutionized care of transcatheter repair of congenital heart defects. Talking about cardiac catheterization, everybody knows that the first human vascular catheterization was performed by Werner Forsman in 1929, and you guessed it right, he did it on himself. He ignored his department chief and persuaded his operating room nurse in charge of sterile supplies to assist him, and he went to the cath lab, did fluoroscopy, and proved that he could put a urology catheter up into his heart. And if you guessed as to how things worked out those days, his prize was he was fired. Finding it difficult to get a job, he became a urologist. I think it was a smart move in that age. He won the Nobel Prize 30 years later in 1956, along with Cornad and Richards. But the great journey of cardiac catheterization began then, and it continues its great journey as we speak today. The first pediatric cardiac procedure in the interventional cardiac procedure was the Rashkind balloon atrial septostomy developed by Bill Rashkind in 1966, which has saved many lives of babies born with retransposition and continues to do so even today. This is a balloon atrial septostomy which I performed here within months of moving here, and we continue to do that in babies with transposition to open up the atrial septum. The original septostomy catheter was developed by Bill Rashkind with his own hand. There was no IRB or anything like that then. And Rashkind then went on to develop several other implanted devices which were used to treat congenital heart disease. Dr. Chuck Mullins from Baylor, who is considered one of the fathers of pediatric interventional cardiology, once said about the Rashkind septostomy, and I quote, "The procedure stirred the imagination of invasive cardiologists throughout the entire cardiology world and set stage for all future interventional cardiac procedures, the true beginning of pediatric interventional cardiology." Both pediatric and adult interventional cardiology have come a long way since then. From the first balloon atrial septostomy of Bill Rashkind in the 1960s, it moved on to the ASD and the PDA devices in 1970s, followed by balloon dilations of pulmonary and aortic valves in the 1970s to 80s, followed by balloon angioplasties of pulmonary artery stenosis and other vessels in 1980s to the stents of 1990s. Things have grown really fast. In the last 10 to 15 years, we have seen innovations in pulmonary valve implantation. We have seen innovations in fetal interventions, innovations in other complex adult structural interventions, such as the mitral clip repair for mitral regurgitation. There are now devices such as left atrial appendage occlusion devices used to prevent stroke in patients with atrial fibrillation. There is transcatheter aortic valve replacement, which has developed in the last decade and basically has revolutionized care of adults with aortic disease. The list of procedures that can be done in the pediatric and the adult structural cath lab today is essentially almost feels like it is endless. Gone are the days when cardiac catheterization was performed mainly as a diagnostic tool before surgery. If you remember, in the 60s, 70s, and 80s, every patient had a diagnostic cath before surgery, and that was because echo wasn't good then. Echo was just M mode. However, nowadays things have changed. Transcatheter intervention plays a significant role in several congenital heart diseases. It is the primary approach to treat most lesions that are marked here in yellow. The ASD, the PDA, aortic stenosis, and valvular pulmonary stenosis are primarily addressed in the cath lab these days. Cardiac cath plays an adjunct role in several other lesions, such as the tetralogy, transposition, and the single ventricle group, where children need repeat interventions as they grow, even after their repair, for residual lesions, such as pulmonary artery stenosis, valve replacement, collateral closures, and things like that. And it is also increasingly being used in select patients with VST and coarctation. For example, an older child with VST or coarctation these days is primarily treated in the cath lab, whereas a younger child with coarctation is primarily addressed surgically. And anybody with recoarctation after surgery is addressed primarily in the cath lab. In fact, in our own experience here at the University of Minnesota, approximately 70% of the cardiac caths that we performed in the last year to 2 years are interventional, and diagnostic cases alone account only for approximately 30% of the patients. So why not surgery? I do not think I need to explain to anyone why one would prefer transcatheter approach over surgery if and when such an option is available, right? Surgery in most instances is associated with increased morbidity, mortality, longer hospital stays, longer days away from work. And in my opinion, the thing that is not talked about most, which is very significant, is the main reason in my mind to avoid repeat surgery is the diastolic dysfunction that surgery causes. Repeat cardiopulmonary bypass, no matter how advanced our techniques of bypass and cardioprotection are, they still cause diastolic dysfunction, and I see it every day in the cath lab. Every patient who has had 2 or 3 cardiopulmonary bypasses in the past, they end up with diastolic dysfunction, ultimately ending up in systolic dysfunction. To give an example, both transcatheter and surgical ASD closures are associated with excellent short-term outcomes. Several studies have shown that despite the high cost of devices, ASD device closure is cheaper in developed countries than surgical closure. Transcatheter ASD procedures have lower lengths of stay, they have lower rates of infection, and lower complications. They have faster recovery, faster time to return to work, and resulting in low overall costs, and not to mention better cost messages, right? Things might not be the same in underdeveloped countries, though. In underdeveloped countries, surgery is so much cheaper than transcatheter devices, so the cost advantage probably favors surgery in underdeveloped countries, but cost message plays a much bigger role in underdeveloped countries. Imagine a girl child in an underdeveloped country with the ASD. It is very important for a girl child to not have a scar on her sternum for social reasons. So transcatheter approach, even though might be slightly expensive than surgery there, still is preferred over surgical approach. So no wonder transcatheter ASD closures have gradually taken over surgical closure. And as you can see here, over the course of 25 years, seen in this data from the national inpatient sample, the gray bars are transcatheter closures, the dark gray are surgical closures. Transcatheter closures have gradually taken over surgical closure. And I'm convinced that if I had the graph extend beyond 2005 to 2016, that proportion is even more higher. To give you another example of cath intervention versus surgery, this is a paper that recently came out of comparing percutaneous pulmonary valve implantation versus surgical pulmonary valve replacement. Vergalis et al. Showed that percutaneous pulmonary valve implantation holds significant cost advantage over surgical approach. It has fewer hospital days, incurs less patient wage loss, and furthermore, they concluded that the percutaneous pulmonary valve has to have a very high failure rate to lose this cost advantage. There is no doubt in my mind that transcatheter intervention is preferred over surgery in most cases, once again, if such an option is available. Moving on to talking about some select procedures that are done in the cath lab today. I already mentioned to you that the list is long, and this is just an example of what all procedures are the most common ones done in the pediatric cath lab, and this is no way complete. The common procedures done include device closures of intracardiac left to right shunts, balloon dilations of pulmonary and aortic valves. We do balloon dilations of aorta, pulmonary arteries, and systemic and pulmonary veins. We can do stent implantation in various places, including the PDA, in patients who are ductal dependent for systemic or pulmonary circulation. We can create holes when needed, just like the balloon atrial septostomy I showed. Sometimes we put a stent in the atrial septum in our single ventricle patients. We can open up atretic valves. We can create fenestrations into Fontan pathways, and not to mention valve implantation in pulmonary and tricuspid positions, and closures of collaterals. In the interest of time, I cannot go over all these today, but I would like to go over a select representative interventions that interest me the most in the next 15 to 20 minutes. We'll start with ASDs. ASDs are the most common congenital heart defects treated in the cath lab today. As you all know, only the secundum type of defect, which accounts for approximately 70% of ASDs, can be closed in the cath lab. And almost all secundum ASDs in the country currently are closed in the cath lab unless they are so big and they don't have deficient rims and you cannot put a device in the cath lab. ASDs are commonly closed before school age for a variety of indications that include right heart dilation, exercise intolerance, failure to thrive, cryptogenic TI or stroke, and in a lot of premature babies or Down syndrome babies who are at risk for pulmonary hypertension, we close ASDs to prevent progression and to prevent pulmonary hypertension as well. There are currently 2 devices available that are FDA approved for ASD closure. The Amplatzer septal occluder is the device that has been there the longest, and it's the most common device used. The other device that is shown here was recently FDA approved in August of 2015. It is called the Gore Cardioform Septal Occluder, and it replaced its earlier version, which was used to be called the Helix Septal Occluder. Transcatheter ASD closure is a relatively simple procedure. It's an outpatient procedure. It involves getting access in the groin using a sheath that ranges between 6 to 11 French, depending upon the size of the hole and the type of device used. We go through the groin, we size the ASD using TE and balloon sizing, and after we decide an appropriate size device, it is advanced over a wire into the left atrium under fluoroscopy guidance. The left atrial and the right atrial discs are deployed, and after confirmation of proper device position, the device is released. The whole procedure takes approximately 1.5 to 2 hours, and patients usually go home either the same day or the next morning within 24 hours with just a Band-Aid on their groin, and they are on over-the-counter aspirin for 6 months. To your right is an example of a multiple ASD device closure that we performed, and you can see both the devices that I mentioned here in this patient. The top one is the Amplatzer septal occluder, the bottom one is the Gore Cardioform Septal Occluder, and they are positioned in the atrial septum between the left atrium that is highlighted here with the contrast and the right atrium here, with excellent result in the same patient. Reported outcomes from transcatheter ASD closures are excellent. This report is from the IMPACT database. IMPACT is American College of Cardiology's suite for cardiovascular data registry. About 100 centers from all over the country enter cath data into this registry, and it began about 5-6 years ago. And this is a report from that database showing us outcomes of 1,286 ASD closures that were performed between 2011 and 13. And it is clear that ASD closures have a high degree of success in the cath lab, 96% closure rates, and very low incidence of major adverse events. In our own experience here at the University of Minnesota, as you all know, under the leadership of Dr. Bass, he's sitting in the back, he was involved in a lot of Amplatzer line of device development here at the university. We have closed over 100 devices, 100 ASDs in the last 4 years with excellent success, 99% success and very minimal adverse events. What's new in the field of ASD? Well, just like in every other field, we constantly work to improving our devices and techniques in order to improve outcomes and reduce risks. New developments in the ASD world are newer devices, which include the bioabsorbable BioStar device, which in theory would result in a collagen device over a very thin metal frame. And after you close the ASD, the collagen disappears. So what is left is essentially this thin metal frame, which in theory, if you can imagine, that means it is less metal, less stiffness of the left atrium, less scar. And when you are 50 or 60 years old, maybe having a less stiff left atrium is good to reduce your incidence of atrial fibrillation. It is just a thought. We don't have any data, but it makes sense. And there are newer designs. This is the Gore Cardioform Septal Occluder that I just talked to you about. It's a softer device compared to the Amplatzer Septal Occluder, because as some of you know, the major disadvantage of the Amplatzer Septal Occluder is its incidence of erosions, which is very low. It's 3 per 1,000, but there is no incidence of erosions described with the Gore Septal Occluder because it's a softer device in studies in Europe and in the pivotal study done in the US, but it is that is the theoretical advantage of the Gore Septal Occluder. And then there are other devices being developed which have a softer and a different delivery mechanism, hopefully making it easier for device closure in the cath lab. In my mind, one other disadvantage of transcatheter closure as compared to surgery is the need for use of radiation in the cath lab and its adverse effects. As you all know, the effects of radiation are especially significant in a young child who is at higher risk due to his active growth, sensitive tissues, and the longer time that he has in his lifetime to manifest the side effects of radiation. And our goal during cardiac catheterization always is to use as low radiation as possible. We call it the AORTA principle. While I was at UCSF, we tried to reduce radiation exposure during ASD device closure by reducing the fluoroscopy frame rate. We showed that fluoroscopy at 4 frames per second can be safe and effective for ASD device closure in children and adults, while trending towards reduced radiation exposure. Here at the University of Minnesota, we continually strive to reduce radiation exposure, and we are very radiation conscious. Our default fluoroscopy frame rates in the cath lab here are now 3 frames per second. Moving on to second topic, very common procedure that we do in the cath lab, the PDA closure. PDA is again a very common congenital heart defect. It is diagnosed in a child when he presents with a continuous murmur and signs of pulmonary overcirculation, and it is closed either by surgery or transcatheter approach to eliminate a left to right shunt, to prevent pulmonary vascular disease, and to eliminate the risk of endocarditis. Transcatheter closure of PDA was first performed by Portsman et al. In the 1960s, and it's a preferred method of PDA closure. A variety of transcatheter devices have been used to close a PDA, but there are only 3 devices that have attained FDA approval for device closure, and those are the Amplatzer Duct Occluder 1, the Amplatzer Duct Occluder 2, and the newest among the devices is the PFM Night Occlude device that we use frequently here at the university. PDAs have also been closed with a variety of pushable and detachable coils and Amplatzer vascular plugs as well. These are angiograms in a 9-month-old in whom we closed a PDA. He was referred to us for left heart dilation. On your left, you see the angiogram here. We have a venous catheter through the right heart into the pulmonary artery, and an arterial catheter using just a 3.3 French sheath in the groin in the artery. And we are injecting contrast in the proximal descending aorta, and you see the PDA connecting the aorta to the pulmonary artery. The technique is simple. We go from the venous side. We put the appropriate size device from the venous side in the ductus, and once the device is released, this is how the post-device angiogram looks, and if you can see, there is very minimal angiographic residual shunt through the device, and I will talk to you guys about it in just a few slides. That residual angiographic shunt usually goes away within 4 to 6 hours after device closure. Once again, based on impact data, this data is from 1375 PDA closures performed between 2011 and 13. It is a very safe procedure. Total adverse events reported were 5.3%, with major adverse events of only 0.2%, with a high degree of success. PDA closure, in the cath lab is done with approximately 99% success rate. Our experience at the university here has been similar. Between 2011 to 15, we closed 114 PDAs in the cath lab with 100% success and no procedure-related major adverse event. The only major adverse event noted was during induction and was anesthesia-related. Sorry, anesthesia, if we're here from anesthesia. I don't want you to go through all this poster here, but this is a poster that we are presenting at the CAI conference in May in Orlando. We here at the University of Minnesota decided to look at our institutional experience with the Night Occlude device with a special focus on the immediate angiographic residual shunt rate that I showed you in that angiogram there. Night Occlude PDA device is a new device. It is simple. It has a high degree of safety and efficacy. Yet the major apprehension in a lot of people which prevents them from using this device is that immediate angiographic residual shunt. So we decided to look at that. We looked at about 30 Night Occlude PDA device closures that we performed in the last 2 years and compared them to similar ADO1 and other coils that were used to close PDAs. The immediate angiographic residual shunt rate in the cath lab right after device release was 70% in the Night Occlude group. It was higher than the other 2 groups, but most residual leaks disappeared by the time of echo 4 hours later, with 90% closure rates at 4 hours, 100% closure rate at 2 months, and it persisted at 100% at 6 months. We concluded that despite the higher immediate angiographic residual shunt rate, our study showed high closure rates within hours after device closure, and that angiographic residual shunt in the immediate post-release angiogram should not be a deterrent in using this device. In my mind, though, the next frontier in transcatheter PDA closure is to expand this indication in the Premie-newborns. As you all know, PDA is seen commonly in preemies, and for more than 3 decades, we know that the presence of a significant PDA in a newborn increases morbidity and mortality. To date, the available treatment options are either medical management with COX inhibitors or sending them to surgery. And as we all know, surgery comes with complications. And there is pneumothorax, hypothermia, bleeding, scoliosis, wound infection, phrenic nerve palsy, vocal cord palsy, etc. But with improvements in catheter and device technology, there are several recent reports of closure of transcatheter closure of PDAs in Premie-newborns using minimal fluoroscopy in such small babies as Evan Zan reported here recently from Cedars-Sinai, in a 960-gram baby who were just less than a month old. Most of them were done with echo guidance as seen here. This is an echo still image. This is pulmonary artery, aorta, and the ductus. The vascular plug was placed with echo guidance, and this is flows through the left pulmonary artery and aorta with the ductus gone and the fluoroscopic appearance of the Amplatzer vascular plug. While there is a slightly higher risk of vessel injury while closing PDA's transcatheter in a preemie baby, I believe we can offer transcatheter closure to this patient population with proper patient selection. And I encourage my neonatology colleagues here to consider transcatheter repair in our smallest babies in place of surgery. Well, we just don't close holes in the cath lab. We can also widen clogged arteries by inserting a balloon. So let me talk a little bit about balloon and stent procedures that we do in the cath lab. I'm running out of time here, so we'll go through them a little bit fast. Coarctation of aorta should be, as you all know, suspected in any newborn who presents with sudden cardiovascular collapse or poor systemic perfusion as the duct closes, or in an older child or an adult who presents with hypertension. Clinical examination would show systemic hypertension, decreased femoral pulses, radiofemoral delay, and blood pressure gradient between upper extremity and lower extremities. For all the pediatric residents who are present here today, systemic hypertension in a child almost means that we have to rule out coarctation. So always feel femoral pulses and get upper limb and lower extremity blood pressure. Evaluation of a patient with suspected coarctation includes EKG to rule out LVH, an echocardiogram to rule out bicuspid aortic valve, which is associated with patients with coarctation, and to look at arch anatomy, and sometimes further imaging using MRI or CT scans to look at the arch anatomy. In the cath lab, we can help babies with coarctation by two ways, either by balloon dilation or by stent placement. Balloon dilation is offered mainly to treat recurrent coarctation after surgery, but it can also be offered as a primary repair for toddlers and young children in whom we don't want to place a stent, because placing a stent, although gives excellent result, commits them to serial redilations as the child grows. So balloon dilation is very effective in recoarctation. It's also effective in native coarctation, but not as much as surgery. But we still use them sometimes for native coarctation in babies who are too sick to go to surgery, just to buy time. It relies on the fact that we tear the intima and the part of the medial layers, and hence there is some risks involved, and the main risk is we tear the aorta and the tear extends beyond the medial and the adventitial layers, either resulting aneurysm or blood extravasation, but the risk is very low. Stent implantation, on the other hand, is extremely effective, but as I said, it commits the child to, a growing child to serial redilations to keep up with somatic growth. Hence, we perform stent implantation in older children and adults where they have big vessels in the groin, where you can put a big sheet to put in a stent, and they are as close to their adult size as possible so that we don't have to take them back to the cath lab, and avoid it as much as possible. A variety of bare metal stents are used. This is a covered stent, and covered stents are used to prevent or treat vessel wall injury during coarctation dilations. Unfortunately, it is not FDA approved for use in this country yet, but it's available everywhere else other than the United States. This is an example of a coarct stent that we performed recently here at the University of Minnesota. This is an 18-year-old male who had a detransposition repair as a baby, had native coarctation that was initially thought to be managed conservatively, but he developed systemic hypertension. On your left here, you see a 3D reconstruction of his MRI showing severe juxtaductal coarctation. This measured about 8 millimeters. The aortic size distal to the coarctation was approximately 27 millimeters. So we took him to the cath lab. We went through the groin, and the middle picture here shows a Palmer's 3910 stent. It's a stainless steel stent that is being deployed using a balloon. And this picture here, an angiogram in the proximal descending aorta after stent implantation, shows excellent result with no vessel wall injury. The coarct gradient in this patient was 25 millimeters before the stent implantation and went to 0 after the stent implantation. Stent implantation from coarctation has been shown to have excellent results. We here at the University of Minnesota were part of one of the biggest trials for stent implantation through the collaborative network called CCISC. There were 17 institutions that participated, a total of 565 interventions, procedures done on coarcts, and half of them were native coarcts. The success rate was approximately 93%, with very low incidence of major adverse events, approximately 1.2% major adverse events. And our experience here at the university has been similar. Over the course of last 4 years, we have performed approximately 57 coarct balloon and stent placement with excellent procedural success and very low adverse events. The next step in coarct stent repair is getting this covered stent approved. As I talked to you about, this covered stent has been shown to save and prevent vessel wall injury when we take up vessels from 8 millimeters to 27 millimeters in size. There is a chance that the vessel gets injured. But the only way currently for us to have access to the covered stent is as part of a course trial, which recently finished enrollment. And the results were published in this month's issue of JACC Interventions. It showed excellent results, and we're hoping that the FDA will approve this covered stent soon, and we'll have it available for use in this country. Moving on to one other topic which is very dear to me is pulmonary artery stenosis. Pulmonary artery stenosis is also a common lesion in pediatric patients, happens in 2 to 3% of all patients. It can be easily treated in the cath lab. And pulmonary artery stenosis, especially when it is unilateral, results in pulmonary blood flow maldistribution. And what this maldistribution does to patients is it leads to ventilation perfusion mismatch, and it makes kids breathe harder to eliminate the same amount of CO2, so they feel breathless. It also increases afterload to the right ventricle, causes systolic and diastolic dysfunction, and not surprisingly, a vast majority of patients with pulmonary artery stenosis develop exercise limitation and dyspnea over time. The thing is, a vast majority of these patients underestimate their exercise limitation. And it's not just patients that underestimate limitation, parents underestimate limitation because they get used to what their new normal is. Cardiologists also are reluctant to sending these patients to a cath lab or for surgical intervention because they think they are quote unquote asymptomatic and the echo otherwise looks normal. I am a PI for a multi-institutional pre- and post-interventional cohort study involving 6 centers in the country, and we are including children about 10 years of age and adults who have biventricular circulations and who have unilateral PA stenosis with a minimum 10% pulmonary blood flow maldistribution, who are referred to the cath lab for balloon dilation or stent placement. And my aim here is to assess the effect of angioplasty and stent placement on exercise capacity, ventilator response to exercise, and subject to symptoms in this patient population. We exercise them before the cath. We get assessment of pulmonary blood flow maldistribution by a lung perfusion scan or MRI, and we assess their MRC dyspnea scores, and we repeat them after cardiac cath within 6 months. The interim results from 16 patients that we had enrolled so far were presented at ACAI last year, and I will try to summarize them briefly here. As I said, the N was 16, and the median age was 20 years with a range of 11 to 66 years. The procedure was technically successful in all patients. As expected, there was a significant decrease in the gradient across the stenotic artery. There was a significant increase in the lumen diameter after intervention. And based on our definition of technical success, which was more than 50% increase in lumen diameter and 20% decrease in gradient, all interventions were technically successful. The median pulmonary blood flow maldistribution was 39% before intervention, and it improved significantly to about 19% by 19% after the intervention. And based on our definition of physiological success, which we had used as more than 5% improvement in pulmonary blood flow maldistribution, the procedure was physiologically successful in 15 out of 16 patients. Irrespective of their subjective assessment of breathlessness, we document that that all patients with PA stenosis had significantly decreased exercise capacity and percent predicted oxygen consumption and oxygen pulse before the intervention. They also had increased respiratory response to exercise, so they were breathing harder, as shown by increased VCO2 slopes before intervention, and all these parameters of exercise improved significantly after the intervention. These findings were consistent with our hypothesis that improvements in pulmonary blood flow maldistribution improved exercise capacity in these patients. But what was interesting was, despite having severe impairments in their exercise capacity, they did not score very high on their MRC dyspnea score, suggesting that they all underestimated their degree of exercise limitation. But when we asked them to score their dyspnea scores again after the intervention, there was statistically significant improvement. So we concluded that there was significant improvements in exercise capacity and ventilatory response to exercise in both children and adults with PA stenosis after intervention, and this correlated with the degree of improvement in pulmonary blood flow maldistribution, and patients underestimated their degree of exercise limitation. So in my mind, all these patients should have formal evaluation by exercise study, even if they are asymptomatic, and should be referred to the cath lab sooner than later, as most cardiologists do these days. I'd like to spend the last few minutes talking about recent advances in the pediatric cath lab. One of the greatest development which I think has happened in the last decade has been the advent of transcatheter pulmonary valve implantation. Patients with complex congenital heart defects such as tetralogy, patients who undergo Ross procedures, are subject to numerous surgeries in their lifetime for valve replacements, relief of right ventricular outflow obstruction or insufficiency, and with each surgery comes incremental risk and significant morbidity. In September 2000, Philippe Bonhoeffer did the first successful percutaneous pulmonary valve implantation in France using bovine jugular vein that was sutured on a platinum stent, which is now called the Melody valve made by Medtronic. Since this first in-man report by Philippe Bonhoeffer, catheter-based valve implantation has evolved rapidly over the last decade, mainly due to the simultaneous transcatheter aortic valve replacement technology that has grown at the same time. And it has revolutionized the care of many of our patients. Currently, there are two devices that are available for use in this country. To your left here is the Medtronic Melody valve. This is a bovine neck valve implanted in a platinum iridium stent, and it can go in sizes between 18 to 24 millimeter. And the newest is the Edward Sapien valve, and this is the same valve that the adults use for implant in the aortic position. It goes between 23 to 29 millimeter, and it is made up of bovine pericardium sewn inside a stainless steel stent. This got approval by FDA for implant in pulmonic position on March 2nd, this month. Multiple studies have shown that Melody valve implantation is safe and effective with high rates of procedural success and durable short and medium-term follow-up, although long-term follow-up is still pending. But the major limitation of Melody valve implant, or for that matter Sapien, is that it is indicated for implantation in patients with dysfunctional conduit or a previously placed bioprosthetic valve. It is not indicated for placement in a native outflow tract, and for all the cardiologists present here, we know that majority of our patients who need pulmonary valve replacements are the transannular patch kind. 85% of the patients do not have a pre-existing valve, and that is the major limitation. And these valves can only be placed in a bigger child, at least 35 kgs, because you need a 22 French sheath to go through the groin. This is a Melody valve that I performed a few months ago here. This was a 12-year-old child who had tetralogy of Fallot, absent pulmonary valve, who had initial repair followed by 2 valve replacements at the age of 3 and 6, and he had a 19 millimeter bioprosthetic valve conduit placed in his pulmonary position at his most recent surgery, but it had become significantly stenotic and it was insufficient, and hence he was referred for transcatheter pulmonary valve replacement. On your left here, this is the valve ring from his original homograft, and this is a tube placed from his right ventricle here to the pulmonary arteries here, and you can see here there is significant calcium and significant stenosis, and the contrast here comes back into the ventricle, suggesting insufficiency. So we decided to open it up with serial balloon dilations. We use serial balloons from 12 14, 16, 18, 20 millimeters and try to move the calcium away and create a landing zone for valve implant. Following which, we decide to do a stent implantation. But before we put a stent, we always have to make sure that we are not compressing any coronary. So we did a coronary injection with the balloon up, making sure there is no coronary compression. Then goes a stainless steel stent, which acts as a foundation inside which the Melody valve is placed. It is known to prevent fractures of the valve itself. And once the stent was placed, this darker stent is the Melody valve itself. The Melody valve placed on a 20 millimeter balloon here, and it was post-dilated with high pressure balloon, and this is the result at the end. The stenosis has mainly been relieved. His gradient went down from 100 to 30, and the insufficiency is not there anymore. And the patient went home the next day. So briefly talking about other newer developments that have happened recently in the field of pediatric cardiology, there has been a lot of advent on hybrid work, hybrid cath lab, hybrid cath and surgical procedures. An example is a VSD closure in a small baby. This is a patient where the baby was too small for transcatheter VSD closure. The surgeon opens the chest, a limited sternotomy, and he gives access to the right ventricle. The heart is still beating, no need to go on bypass, no need to stop the heart. He makes a small incision in the beating right ventricle and provides us a sheath. And after he provides us access to the right ventricle, the interventionist takes over. Under fluoroscopic guidance or TE guidance, he puts the device through the wall of the right ventricle into the VSD, and the device closure is performed and the chest is closed, avoiding all the complex maneuvers that are done in the cath lab in a small baby, which could be risky, and avoiding cardiopulmonary bypass and surgery. Similarly, there have been significant advancements in catheter treatment of single ventricle in all stages of repair. In the first stage of repair, hybrid procedures include ductal stenting, internal PA band placements. There have been advancement in transcatheter Glenn completion, advancement in transcatheter Fontan completions have been reported. There have been advancement in transcatheter rerouting of Fontan blood flow to prevent and treat pulmonary AV malformations. But the most significant advancement in the last decade, which fascinates me the most, is fetal intervention for hypoplastic left heart prevention. This is an example where the interventionist puts a needle through the mother's womb, going through the chest wall of the baby into the aortic valve to balloon dilate a fetal aortic valve to prevent progression of fetal aortic stenosis to hypoplas. And in the interest of time, I cannot go over data on that, but it is just fascinating. Other future directions which are coming up is the development of percutaneous pulmonary valves for native outflow tracts. As I talked to you about, native outflow tracts account for 85% of the patients who need valve implants. There are currently 2 valves that are being developed specifically for native outflow tracts. This is the Medtronic native outflow tract device that underwent 10 implants as a pilot study in this country. And currently there is a HDE trial about to begin in July. And this is the venous P valve that has been used in China for native outflow tract devices. And I'm sure this will expand the percutaneous pulmonary valve implantation to a vast majority of kids who need them. There have been significant advancements in the last 10 years in biodegradable stents. In fact, this year, in the beginning of this year, Boston Scientific became the first company to have the first ever bioabsorbable polymer vascular scaffold to get FDA approval for coronary stenting. This is the Boston Scientific Synergy drug-eluting bioabsorbable polymer vascular stent that, so fascinating for kids, right? Imagine you can put in a stent in a neonatal coact. The stent disappears 6 months later, but the coact is treated, and now you're not left with a metal stent that you have to go back in and redilate every single time. And there's lots of work being done on bioabsorbable stents in congenital heart disease, and hopefully in the next 10 years, we'll see biodegradable stents FDA approved for pediatric patients. There has been tremendous work. There is tremendous technology out in the market for using 3D echo data, 3D volume data from CT and MRI to superimpose that on cath fluoroscopy and in EP procedures since Parveen is here. And this is just an example of 3D data from a CT being superimposed on live fluoroscopy that can help make a lot of our complex congenital interventions safe and more efficient. So there's a tremendous technology coming in the pipeline. Lastly, the days of MRI-guided cardiac catheterization are not far away. Wouldn't be a giant leap for medicine if we are able to perform transcatheter procedures on children without any exposure to radiation. NIH has invested a lot of money and effort into this, and it has done tremendous work in developing MRI cath labs. There are MRI cath labs that are functional in Washington, D.C., at the NIH, at Bethesda, and at CNMC, Washington, D.C. And NIH has not only developed MRI cath labs, but also it has put in a lot of effort in MRI-safe catheters, MRI-safe contrast. And there are reports now, even in humans, not just animal studies, of procedures done with just MRI guidance, like the one shown here. 5 patients with coarctation that were balloon dilated just with MRI guidance in an MRI cath lab. So to conclude, interventional cath lab has replaced surgery for treatment of a majority of simple congenital heart diseases. We have new catheter, stent, and valve technology that will broaden the use of interventional cardiac catheterization to complex congenital heart disease and to our youngest and smallest children. Continued research and development will improve these interventional techniques in order to reduce risks and improve outcomes. With that, I will end. And once again, I thank you for your attention, and I'll open for questions. Yes, Dr. Kaplan.
That was very nice. Very nice. You're to be complimented for that.
Thank you.
Being a veteran of the days of cut downs and having seen what the long-term effect is, as we get more and more able to use the groin in smaller and smaller people, what do we know about the long-term effects on the leg length, etc., in these? And I'm talking about not the acute, getting past the acute, but 10 years or as they get to be adults. And the second question I have is, the tables that you showed were impressive on the various lesions and what has been done for them. Has anybody made those tables 10, 20, 30 years? I realize some of them are very, very, very new procedures, so they haven't gone that far, as you alluded to. But can you tell us anything about whether anybody has made a table going out over a period of time in terms of long-term morbidity and mortality? And again, thank you very much. That was very nicely done.
Thank you, Dr. Kaplan. And those are excellent questions and very interesting questions. And just to repeat what Dr. Kaplan asked, when we do cardiac catheterizations in children, especially in the smallest babies, there's a risk that we occlude the vessels permanently, right? And the incidence of venous occlusion in an infant after cardiac catheterization has been shown somewhere between 10 to 30%. We don't keep looking for them every single time. We try to use benign neglect, but it becomes significant. Venous access, not such a big problem. It's usually a problem because we cannot go through the same groin the next time. But arterial occlusions and stenosis, on the other hand, are significant, right? There could, arterial occlusions are not as common as venous occlusions, but in the smallest infant, there are reports of acute effects of arterial occlusion, which could be ischemia, gangrene, and late effects where patients can present with claudication symptoms as they grow older, needing vascular surgery. Or the most common side effect, which Dr. Kaplan alluded to, is leg length discrepancy. Unfortunately, there's not a lot of data on it, and there is various reports of leg length discrepancy, but in my own personal belief, and I'm talking without any data, is that the incidence of arterial occlusion from transcatheter, from cardiac caths, probably has gone down significantly with the advent of newer and slick sheets, now we have 3.3 French sheets, which were never there at the beginning of my fellowship 4 years ago. The smallest arterial sheet was 4 French. Now we have 3 French sheets, and they make a huge difference. There has been a lot of work done on this from the CHOP group, and we are now very careful. We look for vessel arterial occlusion. When we hold pressure, we have a pulse ox on the foot all the time to make sure that the pulse ox has good tracing. If we do not have a pulse 4 hours after recovery, we do a Doppler, and we are very diligent in starting either TPA or heparin. So the incidence is lower, but to be specific to your question, I don't think there is data long term as to how many of these patients end up having leg length discrepancy, and I think it would be an interesting project for a fellow to take over. I will answer the second question, and then I'll come to you, Dr. Naglia. The second part was, is there any long-term data on these transcatheter interventions? There is data on a few, but not at the scale as to which we want them to be. For example, there is data on what happens after ASD closures 20 years down the lane. And we know that there is slightly increased incidence of atrial fibrillation because a big device causes stiffness to the left atrium and the compliance is lower. But whether that long-term data is to 50, what happens when the patients are 50, 60 years old, I don't know. And we do not have long-term data beyond 5 years for a lot of other interventions. At least I'm not aware of the data.
Is anybody collecting it? The data?
I'm not aware because the pivotal studies on ASD closure, for example, the MAGIC study, the GORE pivotal study, and the Amplezer pivotal study, they all stop at 5 and 10 years. 20 years follow-up, I don't know, but it is certainly interesting to look at. 20, 30 years down the lane.
But do the cardiologists follow up? What is the recommendation for, let's say you put in an ASD device, 5 years down the road, 10 years down the road, 15 years, do they follow up, or we say, bye, we're done?
The recommendations are initially you follow up, 2 months, 6 months, year, and then yearly afterwards for 5 years. And then there are really no recommendations. It's all style. Dr. Naglia? Yes.
Just one of your early slides showed the use of surgical closures versus device closures for ASD, and that the proportion that were closed through devices was growing. But what struck me on that slide was the dramatic increase in the occurrence of ASD in the population. Is that just a remnant of better detection, or?
That's an excellent observation, Dr. Naglia. Tara wrote this paper. Tara was a cardiac surgeon at UCSF. So when Tara looked at it from Michigan, and that is exactly the same observation she makes in the study, that the prevalence, it seems like the prevalence of ASDs went up from 1.34%, I believe, to 2.5% or something. And she doesn't give we don't know the reason, but she postulated that is because with the availability of transcatheter repair, there are more and more people sending patients to surgery, and some of it also included the age when PFO closure was becoming a fashion, right? And that slide actually included ASD and PFO closure. If you remember, in the 1990s and 2000s, people started referring a lot of adults for PFO closure, adults who have had strokes, who have had migraines, to prevent strokes. And then the early PFO closure data showed that closing PFOs did not reduce the incidence of stroke, which we don't believe it is true. Well, at least the interventional cardiologist doesn't believe that is true. We believe it helps. And there is the most recent study, which is the interim results are out. And this is an excellent study performed by using the GORE septal occluder. The long-term results will be out next year. Shows that there will be benefit. But there are several studies that came over in 2000 saying, this shouldn't be done. And the insurance started denying PFO closure. So, but that period covers that increased incidence of PFO being referred for transcatheter closure. Yeah.
I thought that was a fascinating presentation, and I was especially interested in the fluoroscopy data that you presented. So you showed slowing down the frames. And is there still some concern with the amount of fluoro that's used? And is there any work going on at maybe partial using guided ultrasound for part of the procedure?
That's a great question, and it is something that really I'm very passionate about, and maybe it's a topic for a separate grand rounds. And there is so much data coming out about radiation and its side effects. There is data to show that congenital heart patients have more cancer than other patients, and is it because they are more at risk for cancer biologically, or is it because they get thousands of X-rays, 50s of CT scans, and so many cardiac cath procedures? We don't know. But there is a very strong initiative by American College of Cardiology, and there is a RRR for quality improvement on radiation reduction in the cath lab. And the entire pediatric cardiology community is committed to reducing radiation in the last 5-6 years. So everybody has reduced fluoro frame rates. Most centers in the country use 15 frames per second. But it's not just fluoro frame rate. We have to do so many other things to reduce radiation in the cath lab, from reducing the dose, cine, etc. And we are using a lot of echo guidance as well to do the same. And for ASD closures, we don't use the lateral camera anymore. We park the lateral camera in the back, use just fluoroscopy using the one plane, and 3 frames per second is so much lower than what interventional radiologists use, which is standard is about 7.5 to 15 frames per second fluoroscopy. Thank you.
You have been